This case will be presented by Professor Pierre-Henri Krupp and is entitled Achieving Normal Optimal Management in Patients with Type 2 Diabetes while Considering the Risk of Non-Compliance and the Potential for Future Kidney Function Decline.
Thank you very much, Mariana. It's my great pleasure to go through this case. And here we now consider non-compliance and also the potential for future kidney function decline, which is an important aspect. And I will, before I go through the case, just highlight that diabetic kidney disease is common, and also the consequence of diabetic kidney disease are grim. So we have to take action and take potential diabetic kidney disease into account when we tailor the treatment. So I'll come back to that later on in my presentation here. But this patient is 62-year-old Maria, and she was diagnosed with type 2 diabetes about 10 years ago. And she has hypertension, dyslipidemia, but she also has rheumatoid arthritis, which of course complicates her situation. And of course, she tries to keep fit and goes to exercise classes a few times each week. But now she comes to see the doctor because she's struggling with the glucose control. And she's taking a lot of medications and admits not to be consistently compliant, which is, of course, something that we see a lot in our patients with polypharmacy. So if you look at her current treatment regimen, you can see that for the type 2 diabetes, she has metformin, 1 gram twice daily. She is on enalapril, 20 milligram once daily for the hypertension. Simvastatin, 20 milligrams once daily for the dyslipidemia. And of course also the amlodipine, 10 milligram once daily at night, also to control her hypertension. But then because of the rheumatoid arthritis, she is also on methotrexate, 7.5 milligram per week, and also paracetamol as needed. And of course, given the number of medications she has to take, she's very concerned about the number of medications she's taking. And this is a problem that many of our patients are facing. And not always are they telling us that they are not taking the medication. So as doctors, we actually need to be vigilant and understand that that's the case. But Maria tells us that she's concerned about the number of medications here. So what about then the clinical characteristics here and the assessments? You can see that A1C is 7.8%, which basically means that she's not well controlled. And let me draw your attention to the fact that in any patient, if we accept anything above 7%, for instance 8% in A1C, we also accept that the patient will have about 32-34% increased risk of cardiovascular disease. So good glycemic control, optimal glycemic control is important, to prevent further complications in the future. So 7.8% is above what we want to achieve. The body mass index 23 kilos per square meter, so she's not obese, she's normal weight, and the body weight 67 kilos. eGFR 65 ml per minute. So this patient actually is below the normal value of 90 ml per minute. On the other hand, at the age of 60, we can expect that there will be lower eGFRs. And just, I'll come back to that a little later on, at age changes in the eGFR because you lose kidney function by aging. So her creatinine was 0.71 milligram per deciliter or 63 micromole per liter, and that gives then the eGFR of 65. So according to the KDIGO classification, she has a CKD stage 2, but she's very close to CKD stage 3. And eGFR below 60 is a warning sign. Then you need to start to think about do we see accumulation of drugs that we are prescribing, etc. But so she's on the edge. Her blood pressure 133/74, so she's well controlled. The pulse 58 beats per minute, normal, and LDL cholesterol 80.4 milligram per deciliter, or equal to 2.1 millimole per liter, and the HDL 34.8 milligram per deciliter or 0.9 millimole per liter, which is rather low for a female. Now, the question is, what do we need to consider when or take into account when we look at her medical history and assessment? So the questions here are, so what are the main considerations when we review her case? And of course, I think there, as I already said, there is a need for strong A1C reduction. Just take into account that if we accept higher A1Cs, we also accept higher risk of comorbidities in the future. This is something that we need to always remember, and of course always try to get the best optimal glycemic control for our patients. Although it will take a long time, of course, before you see the benefits of good glycemic control as seen in many studies, but always you need to go for that. Of course, there is also risk of further kidney function decline. And when we come up to an age of around 40, all of us will start to lose kidney function. And if you read the textbooks, it's about 1 ml per minute per year. And let me also draw attention to the fact that if you look at females, females in the general population, no diseases whatsoever. At the age of 60, every fourth female will have, by definition, eGFR below 60. And 60 we are using as 2 standard deviations below the average. So it's the same as we are using osteoporosis, 2.5 standard deviations below the average, which is the T-score when we diagnose osteoporosis. At the age of 60, every fourth female will have, by definition, osteoporosis. At the age of 80, every second female will have, by definition, osteoporosis. And every second female will have CKD, so an eGFR below 60 at the age of 80, without any diseases. So this in the background, and then we have superimposed on that diabetes. So there is really a risk of kidney function decline in our patient with type 2 diabetes. Of course, also what we have to look at in this patient case, because she has to take a lot of medications, so the adherence. And the age I was already alluding to, what with age come losses. And of course, comorbidities. She has hypertension, she has dyslipidemia, and of course the polypharmacy. So it's a full hand that we have to deal with when we tailor her treatment.